All right, thanks to Sages, and big thanks to the Penn State and UCSD guys. I borrowed quite a few videos and pictures. A spoiler alert, your patient probably ate the thing we're talking about. And it's my disclosures. 7 seconds, enjoy this turtle swimming in slow motion. So 3/4 of foreign body ingestions happen in kids somewhere between the ages of 6 months and 3 years, and most of these will pass. I think it's important to point out that mortality from this is low, but it's not zero. And as I said, most of these will pass, but some won't. And some that don't pass can cause complications. But with good endoscopic management, it's pretty rare to need surgery. And before I go much further, I want to acknowledge the elephant in the room, which is that I know you're not really here to learn about endoscopic management of foreign body. I know that you're here for me to show you crazy abdominal x-rays and you try and guess what the object ingested was. So we can just get to it. Anyone guess on one? Anyone? Nail clippers coming up, so that's a scissor blade. 2 is a necklace. It's a paint can opener, which is impressive. And then the nail clipper. And with this bad joke is a good learning point, which is that in this patient, the radiograph was a lot more helpful than the CAT scan because there was so much scatter from all the metal. So don't underestimate an abdominal X-ray. So I think it's helpful to at least briefly divide our discussion between pediatric and adult populations, and that's because in kids, the ingested foreign body is likely to be an actual foreign body, and by far and away, coins are the most common thing ingested, which is great because coins usually pass and don't cause trouble, but the problem is that coins and button batteries look very similar on radiograph. So this is from the landmark. We put a battery on a pork chop trial, and you can see a pretty good amount of tissue damage at 15 minutes and even at 2 hours. So the other thing is that because they look so similar, you have to pay really close attention to the radiograph. So on the left, you can see this step-off appearance. It's also called a bilaminar structure, so this is most consistent with the battery, whereas a coin has crisp edges. And to kind of go further down this rabbit hole, this is that bilaminar shape. Again, you can see kind of the 2 circles there. The other tricky thing about kids is they can't exactly tell you, like, hey, there's something in my esophagus, or, oh, there's something in my trachea. And sometimes a chest x-ray is helpful. You can see in this patient, you see the airway kind of off to the right there, and this indicates that this is probably an esophageal foreign body. Magnets deserve a special mention. So really high-powered magnets are very common now. They're made out of neodymium, and they're in supplies, they're in toys, and certainly ingesting multiple magnets can be a big problem. And some of them are so powerful that they can even get lodged and stuck onto like a belt buckle or external jewelry. And then I also want to talk about super absorbent polymers. So this is out of the Missouri Poison Control Center website. And you can see, these little tiny jelly bean looking things that expand rapidly when they mix with water. So not hard to imagine a kid, eating this, and then also not hard to imagine a bowel obstruction from this. In adults, 95% of foreign body ingestions are related to food, things like chicken bones or fish bones. But so this was literally my first attending case. I just graduated from my pretty cushy, completely elective foregut fellowship, and I'd basically forgotten the colon even existed. And then this guy came in the ER with free air, so. Of course, I took this picture and I went and I showed the family, and the daughter said, "Yeah, well, Paul always likes to have a toothpick in his mouth." So that was a pretty weird introduction to the South, but so it goes. This is a cool graph. It just kind of talks about accidental and intentional foreign body ingestion. So you can see accidental is almost always alcohol related. And then for intentional, it's usually either related to someone being in a police custody or certainly mental health disorders. But for adults, like I said, most of the time these are food impactions. So this was my post-op day 6 gastric bypass who had apparently been eating gum, and she had eaten so much gum that it had just kind of wedged right in the GJ anastomosis, and that was fun. Able to get that out with a Rothnet, she did great. This is a nice table, just kind of talks about different places in the esophagus that things can get lodged and some underlying pathology, things like Zenkers or strictures or eosinophilic esophagitis. So let's talk about workup a little bit. So history and physical is important. So, what was swallowed, when was it swallowed, and have you had prior episodes? So this is that same x-ray that I showed you guys at the beginning. So this patient came to our ER and he had what looked like a pretty fresh X-lap scar. He, of course, swore that he had never swallowed anything before, and it certainly wasn't until we got in there that we realized he had certainly swallowed many things before and had a lot of recent surgery. Symptoms are important, so drooling's a big one. So if your patient is drooling a lot, if they're not tolerating liquids, that suggests a complete esophageal obstruction, and that's someone that should get an endoscopy right away. Crepitus can be helpful, indicating perforation, and location of pain can be helpful, though it doesn't always correlate with where the foreign body is. Labs, certainly if there's a perforation, might have a high white blood cell count, but really the crux of diagnosis hinges on imaging. And I do want to point out briefly that, if someone's looking in front of you and they have a complete esophageal obstruction, you shouldn't delay treatment for imaging, but it's pretty rare that we don't have time for a quick X-ray or a CAT scan. And then management really hinges on the presence and severity of symptoms. What is the object? Where is the object? Is it a sharp object? So just briefly, anything lodged in the esophagus should be removed within 24 hours. And in terms of things that you really have to get up out of bed for in the middle of the night, so a complete esophageal obstruction, like we talked about, batteries, magnets, and then really sharp objects. And theoretically, everything else can wait up to 24 hours, but it's well established that the longer you wait, there's a higher risk of complications, so they really probably shouldn't wait too long. And then things that move on to the stomach, so urgent needs would be something really sharp, or, if an object's big, greater than 5 centimeters, or really thick, like 2 to 3 centimeters, it might not pass the duodenal sweep, so sometimes you have to go in and get those. And otherwise, you can do expectant management with weekly radiographs. We ask the patients to monitor their stool. And then treatment failure is considered more than 3 to 4 weeks in the stomach, or greater than the week in a duodenum, which I agree it seems like kind of a long time to let your patient walk around with a foreign body in the stomach. And then once the object's beyond the ligament of Treitz, all you can do is kind of watch with radiograph. Now, you could go after it with like a push or a double ballooned endoscopy, but typically that's not required. So these are the principles of endoscopic management. I stole this slide from Eric Paul, and I think it's excellent. So airway management, I would intubate all these patients and recognize that the overtube is a really helpful tool. So you can imagine if you're removing a bunch of different objects, even with an endotracheal tube in place, sometimes these objects fall in the oropharynx, et cetera. And when the patient then gets extubated, that foreign body can then go right into the trachea. So the overtube is very helpful for that. Endoscope of choice, certainly if you're doing like a big food impaction, it's nice to have a really big channeled scope or a dual channel scope, so it can be helpful. And then I think the biggest thing, and this is true of endoscopy and really all of MIS, is to plan ahead and just know your tools well. Most foreign bodies we're going after, and this has been brought up a few times, but the rat tooth grasper is an excellent tool. Can certainly use a snare or a Rothnet as well. Other things, this is one of the most simple but I think brilliant inventions. This is a sharp object retrieval hood. So it's a little piece of plastic that goes over the endoscope, and you grab a sharp object, and as you're pulling it out, once it gets to the GE junction, it actually flips up and protects the esophagus. So one of my favorites. But we've seen similar, but so this is a patient with achalasia with just a ridiculous food impaction. You can see that the poor endoscopists are going to deploy a Rothnet here to help, and anyone that's done these cases know how miserable they are. But and you can see even with the biggest Rothnet, you're only pulling out like little morsels of food. So you do this over and over and over again, and with a lot of irrigation, theoretically. And then these guys are using an overtube as well, which kind of drives home that point. Sharp object always comes out last, and protect the esophagus. This is a great video from the Penn State guys. So this patient ingested a bunch of magnets. So I think a few things to learn here. So, these endoscopists, they start with a snare, and in this case, the magnetism of the snare, of the magnets on the metal snare is actually inhibiting them. So they switch up their tool to, I think it's a poly loop they're using here, which is kind of brilliant. It's not what that instrument's designed for, but because it's not metal, they have a lot better luck. So they're able to kind of wedge underneath the stack of magnets and then pull it out. And the next part of that is you got to make sure you get them all out. So you'll see once they're able to get this this stack out, they're going to go back in and look for other magnets, which you'll see there's another magnet on the inferior aspect of the incisura. And in this case, they're using a metallic instrument it's actually helpful to get the magnet out. And then this part's huge. So, you got the object out, you're all high-fiving, but you have to go in and look and see what damage was done. And certainly using a cap is highly recommended to look as their full thickness injury to something need to be clipped closed. And then don't forget to manage the underlying pathology. So if it's a stricture, consider dialing it. If it's a mass, consider biopsying it. If it's achalasia, send them to Nashville so I can do a poem on them. So you can do all kinds of things. And a few other things. So patient positioning, know what you're going after, know where it is, and then position the patient in a way that's helpful. And don't be afraid to use fluoro, super helpful. Make sure you got everything out. And then also you can do leak tests. You can put contrast down and take some x-rays. And then I think, there's so many current and also past bariatric procedures that involve putting foreign bodies in people. So I think it's helpful to kind of have just a little subsection talk about gastric bands. This is from UCSD, but you'll see in a second on retroflexion, this is a patient that has a gastric band that's almost completely eroded into the stomach, and going after these surgically is not fun. You end up creating a huge hole. So the UCSD guys were able to fish a wire around this, and they do this type of wire lithotripsy, which seems terrifying to me, but it sounds like it works out okay. So with the wire around, they're going to pass a snare down their working channel, and then they're going to fish that wire through their snare. You can see that kind of right there. It's a great video. And then once that's through, they're going to pull this out, and there's this external device. And I guess it's a very similar technology to how like stone lithotripsy is done in the biliary tree. And there's this big device they kind of cinch down. You can see the band break open, which is just super cool. And then this is a great one out of Penn State. So gastric balloon. So this was a gastric balloon migration that had made it, through the stomach, duodenum, and into the terminal ileum. So you can see the endoscopists, they used a bunch of different tools during this case. They're the rat tooth. They used a snare at times. And with a ton of patience and persistence, they're somehow able to get this out, which is pretty crazy. And I spared you guys the up close of the rectum as this came out, but it's impressive. Yeah. Cool. And I think that's all I got. Thank you so much. Happy to take questions.